We just need to obviously wait until 2 o'clock when everybody has joined us, and we'll make a start, and I'll do the introductions. But welcome, but if you could bear with us for a few moments.
Sabina, if you're still on, would you be able to resend Ian the link because he's struggling to get on?
Sure, yeah, I'll do that.
Good afternoon, everybody.
Hi, Darren. Hi, you all right?
Hi, Sue. Yeah, I was just checking my mic was working.
Yeah, no
You
problem.
never know with these laptops, do we?
Good to see you.
So what's the running order today? We're just showing the video and then questions.
That's right. Yes. Yeah. Okay. We've got one or two on already, Andrew. So I'll just wait until 2 o'clock and then we'll kick off.
Okay.
Who's on from our side today, Andrew? I think it's you, me, Justin, and Ian. Is it when if Ian can get on? I know he's having a problem getting on at the moment, isn't he?
Yeah. We've got Flo on as well, Darren.
And Flo. Yeah, and Carl, and you, Carl, don't forget yourself.
And me. I'm lurking in the background though.
Sue?
Yes, Helen.
I've got a note saying here that Elizabeth Warren is waiting in the lobby.
Yeah, if you want to let people, because people are already here, so just let people in as they
should I just admit?
Yes, yeah, lovely.
We've got 5 minutes, and I'll just go offline for a bit.
Okay. Welcome to those who've already joined. We're due to kick off at 2 o'clock, so if you could just bear with us whilst other people join in the next 5 minutes. But welcome, everybody. We'll just wait a couple more minutes for people to join us as we're due to start off around 2 o'clock. But welcome everybody. So good afternoon, everybody. Welcome. My name is Sue Venables. I work for the Clinical Commissioning Group. That's the organisation that buys or commissions services, health services for people living in Leicester, Leicestershire and Rutland. Whether it's your first time on one of the events this afternoon or whether you've previously joined, very welcome. What we'll be talking about in the session is the proposals to build better hospitals for the future in Leicester, but for the whole population of Leicester, Leicestershire and Rutland. Quite an informal session this afternoon, as we haven't got huge numbers. So what we'll be doing is we'll be just showing a short presentation which will give you a little bit of an overview in terms of the plans, and then I'll be introducing you to colleagues who are on the call today, who will be able to answer a range of questions that you might have around all aspects of the proposal. But also it's as much about us listening, so if there are comments that you want to make, please feel free to do so. We are recording the session this afternoon, and we've also got people working behind the scenes really to capture your insights, the things that you're telling us, so that we make sure that contributes towards the consultation process, as we're very keen to collect all the thoughts and those things that matter most to people as part of the consultation. So after we've shown the video and we've introduced people, then what I hope is that you'll feel able just to pop on your mics and your video and make any comments that you have. If you could just introduce yourself. And then we will continue until we've got through any questions that there are. So if I can pass over to Carl, so if you could just start the video, please.
We want to spend £450 million to improve acute hospital and maternity services in Leicester. This means the services provided at the Leicester Royal Infirmary, Glenfield Hospital and the General Hospital. We want to see improved patient care, better patient outcomes, and have staff working in the best place to make this happen. Most of all, we want to deliver hospital healthcare that is fit for the future. This is your chance to find out more about what is being proposed and to have your say. This will help your local NHS understand what the changes would mean for you and help us make a final decision.
What we don't want is a health service that's designed only by the people who work in it. It's got to be designed by the people who experience it and use those services.
The proposals include 2 super intensive care units, one at Leicester Royal and one at Glenfield Hospital, with 100 beds in total. That's almost double the current number. Modernised wards, operating theatres and imaging facilities. The first dedicated single-site children's hospital in the East Midlands, based at the Royal. And a new maternity hospital. Currently, there are 2 units on different sites, the General and the Royal.
Obviously, having 2 sites means that sometimes we're spread too thinly. When we're really busy, when we haven't got enough rooms, or when we haven't got enough staff to look after the women, especially in labour, women need one-to-one care. We have to transfer activity from one site to another. So we would envisage that with a new larger hospital where we pooled the staff together, that likelihood would happen less often. The beauty of it is that they're going to be in one unit, and if there is an emergency situation, they can very quickly have access to the obstetricians and the neonatology.
Under our proposals, Glenfield Hospital will become a major planned care treatment centre, with welcome centres to put you at ease and help you find your way around the hospital. These changes would enable us to separate emergency care and planned operations. This would help prevent treatment being delayed or cancelled when the emergency services are busy. More than 100,000 day case procedures and around 600,000 follow-up appointments take place every year at the city's hospitals. The move will free up capacity at the Leicester Royal Infirmary and help ease issues of access and parking there.
Let's take a patient, for example, who's having a planned daycare surgical procedure. They will receive their pre-operative workup on this site, so all the tests and things they need doing before the operation. They will have also been seen in clinic on this site, have the decision made that they need an operation in the first place. Then they'll come to this site, they'll have their operation and go home the same day, and any follow-up that's necessary after that will also be provided on this site.
Leicester General Hospital will become a community health campus. It would include facilities such as the Diabetes Centre of Excellence, a dedicated imaging hub, condition. This will make it accessible to more people and provide a better and safer experience for mums. Today's modern medicine and technology means many patients don't always need to stay in hospital to get well.
Over the last 30 years, the NHS has cut its beds by about 50%, which feels counterintuitive looking at the population growth. But when you take into consideration the change in medical practice over 30 years, so hip replacements used to come in and be in hospital for over a week. They're now staying in hospital for around 2 days. We've got sort of robotic surgery now and keyhole surgery, which means patients don't stay in hospital as long. And we used to prescribe bed rest for patients. We don't do that anymore either.
And for some conditions, you can be cared for at home or where you live.
If you need to be in hospital, so you need treatment or you need investigations that can't be unity, or for instance, you're acutely unwell and you need the investigations doing straight away, hospital is the right place for patients. But there's certainly patients where their medical treatment can happen at home, and it's much nicer for the patient if you can have all the care investigations done in your own surroundings, done at local community hospitals with doctors, nurses coming in that will be the same faces that they see on a daily basis. It's about having safe care, but in the best way for the patient, the most suitable way.
At the moment, our hospitals and our staff, while doing their best, are spread too thinly, trying to provide 21st century services in outdated buildings with limited resources and opportunities for change. We want to achieve a service based on our future healthcare needs, not the legacy of the past.
Leicester's hospitals merged in 2000, and whilst that merger was very successful, it left one issue unresolved. and that was that many of our clinical services, the location of those clinical services is more a product of accident than design. They're split across more than one site. Our staff are spread thinly and our equipment isn't always in the right place. And that can lead to difficulties with staffing our services in the way that we would want to do optimally. I'm really excited by these changes. I think that this is a once-in-a-generation chance to provide care in Leicester, Leicestershire and Rutland that will be state-of-the-art, will give patients a much improved patient experience, give them access to modern medicines, modern treatments in modern buildings. And I'm really excited by this, and I hope that people will be when they see the plans of what we're planning to try and do for Leicester, Leicestershire and Rutland.
You can see the proposals on our website and fill in a questionnaire to give us your views.
Okay, thank you for that. I'm sorry if we've got a few gremlins in the works on the video there, but hopefully you got the gist of those plans. And as I say, we've got a team here who can clarify any points that you might have. So I'm just going to introduce members of the team before I open up for questions. And I'll start with first of all with Flo, who you also saw on the video. So Flo, would you like to introduce yourself?
Hello, my name's Flo Cox. I'm the community midwifery matron, so I look after all the community midwives in Leicester, Leicestershire and Rutland, and I'm in charge of St Mary's Birth Centre at Melton.
Thanks, Flo. And another person that you just saw on the video there is Andrew. Andrew.
Hi everybody, my name's Andrew Furlong. I'm the medical director for University Hospitals of Leicester.
Okay, and if I could invite Justin to introduce himself.
Good afternoon, everyone. My name's Justin Hammond. I'm the head of the Programme Management Office for the Reconfiguration Programme at UHL.
And Darren?
Hi, good afternoon, everyone. My name is Darren Kerr. I'm Director of Estates, Facilities and Capital Development at the University Hospitals of Leicester.
And Ian?
Hello, I'm Ian Scudamore. I'm an obstetrician and gynecologist, so I'm a clinical consultant and I'm the clinical director for Women's and Children's Services.
Lovely. And if I could ask Alice to introduce herself as well.
Good afternoon, everybody. I'm Alice McGee. I'm the Director of People and Innovation for Leicester, Leicestershire and Rutland CCGs.
Lovely. Okay, I think that's everybody. So just in sort of usual traditions of Microsoft Teams, if you've got any questions, if you just want to raise your hand and then I'll come straight to you. Or if you feel that you'd rather put a comment or a question in the chat box, then please do. But I think as there's just only a few people on today, it would be nice to be informal and ask people to put their videos on. So I'm not showing any anything in the chat box or questions at the moment. So I'll just ask. Oh, sorry. Yes, Elizabeth, your hand was up. Do you want to come in?
Yes, please.
Hi, Elizabeth. Hi, welcome. Nice to hear you again.
I want to ask a question about the recent report from Donna Elkenden about the Shrewsbury and Telford Maternity Hospital. I've only managed to have a very quick look at it, but I've noticed that one of the recommendations is that each trust board must identify a non-executive director who has oversight of maternity services with specific responsibility for ensuring that women and family voices across the trust are represented at board level. They must work collaboratively with their maternity safety champions. I don't know whether UHL already has something like that in place or whether there are plans to set that up in the near future. with regard to the proposal for the trial of a standalone midwife-led unit at the General, I thought I read somewhere that there had been some kind of suggestion of a consultation panel being set up to see how that went. But I've looked for it this morning and I can't find it. So I'd like to know what plans there are, what is already in place and what plans there are for the future.
Lovely. Okay, thanks for those questions. That's really useful. So sort of three key areas there. So the reports that's come as a result of Royal Shrewsbury Hospital and the really the here and now in terms of feeding into the midwifery-led unit, and then in the future where that is being developed. So I think perhaps Ian and Flo, can I bring you in on the report based on the findings at Royal Shrewsbury Hospital?
Yeah, sure. So 2 or 3 things. First thing is the report is an interim report on the first 250 cases that they've looked at, and we haven't had a chance to digest it properly yet because it was only published on Thursday. And obviously we've got kind of day jobs that we need to address, but it's something that we need to look at very carefully, and we will be looking at over the next few days. Actually, we've already got a team within the CMG looking at it with regard to doing what we call a gap analysis, so evaluating the things that are in the report and what we call benchmarking them, so comparing them against the way that we provide our own services and our own governance within the the UHL service. So we will be taking this very seriously and making sure that the recommendations of the Ockenden report are applied to our own services. And equally, actually, Liz, we're doing the same thing with the CQC report into Nottingham University Hospitals Trust, which you probably will be aware of too. With the CQC having done an interim inspection in Nottingham because of various concerns that they were alerted to, and identifying some areas of concern in services in Nottingham. So we're going to make sure that we look at those and we incorporate any recommendations that we feel we need to into our own services and into the plans for the reconfiguration going forward. So I mean, my understanding from the Shrewsbury report at this stage is that there were some concerns about the working relationships between some of the staff. There were some concerns actually about standalone midwifery units in the community and poor outcomes because of the way that they were run to some degree. There were concerns also about a reluctance to progress to caesarean section where that was felt to be necessary and appropriate. And those are things certainly that we need to look at very carefully. The second issue was having a non-executive director. We actually have had a non-executive director involved in our service for over 12 months, for about 18 months. And it's one of the non-executive directors who has a background in public health and is completely independent in the context of the trust, which is the role of a non-executive director. She is one of the maternity safety champions, but actually her role has been, we've taken the view that we would like her role to be a little bit broader than that. It's not at the moment in the context of ensuring that there is a representation of families and service users at board level. But I would expect that if that's what the Shrewsbury report says, that we will have conversations with the board and with Vicky with regard to enabling her and encouraging her to take that sort of role and responsibility. Now, one of the things that I think is relevant to that is that the local LMNS, the local maternity and neonatal system, is one of the important recommendations and groups that has been set up to be responsible for maternity service provision in local areas and on a regional basis from the transformation programme through Better Births. And we've got a very active LMNS. The LMNS, in fact, is something that was easy for us to set up locally because we already had collaborative working across the system in LLR, other centres and other services have found it really quite difficult to set that up because they've had to put those things in place. But because we knew it was the right thing to do, we've been doing it actually for quite a long time. And so it was quite straightforward for us to set up, and we've just had to adapt it. And we have been boosting the governance and quality component of the LMNS. But the LMNS has a very active Maternity Voices partnership. We've got a very active section of the LMNS, which is working with the local population and with our service users. And I would expect, therefore, that it should be fairly straightforward to plug that into a role and responsibility for a non-executive director in the kind of role that you've just suggested would be appropriate as recommended by the Ockenden interim report at this stage. So I hope that answers the questions. I think it's an very important report which we need to assimilate properly and compare it to our own services and see that the lessons that we can learn that are going to be important to implement locally. And yes, we do have a non-executive director, which we've had for some time. And because of the structures that we've had in place for quite a long time, which are consistent with the transformation programme, I think it should be straightforward, or relatively straightforward, to incorporate a recommendation to include service users and local people at board level.
That's lovely, thank you, Ian. And I suppose just to add,
I wanted to add to that as well.
Oh right, okay.
That we do use our Maternity Voices partnership, and we use other groups as well, like the Sharma Women's Group, and they're very involved. They come to the LMNS when we're passing guidelines. We're looking at some new screening for mothers who are rhesus negative, and I've asked the Maternity Voices partnership to have a look over the guidelines and to make sure they're user friendly and that families are happy with the way that we do things. So we do use them, so I don't think it should be too difficult for them to transition over. I've got the report in front of me, actually. This is what I do on a weekend. It's very sad. We only got it yesterday. So as Ian said, we will be benchmarking as a trust. And a lot of the things in there, I can say just by reading it that, you know, we don't have issues with the way we work together, obstetricians and midwives. And I can only see that this will be a positive thing if it improves safety in maternity services. But, you know, we come from it from a completely different angle. We're on the opposite end of the scale to Shrewsbury and Shrewsbury.
That's great. That's great. Thanks, Alice. And also, you are right, Elizabeth. You did see something with regard to if the proposals go through and the midwifery-led unit is developed, then we would be setting something up in terms of taking the learning from other areas. So if I can ask Justin just to describe a little of what we know around that and what the proposal would be.
Hi Elizabeth, thank you for the question. We know that it's really important that with the use of the midwifery-led unit, when it's moved over to the LGH pending the outcome of consultation, that actually we don't just look at that from a health perspective, but we look at that from a community perspective. And because of the commitment the Trust has to co-production in a lot of different areas, not just in this one, we've looked at other areas that have done it before us. And where they've been really successful is when they've set up a multidisciplinary panel that effectively sits over the period of time, 12 to 18 months, meets regularly, sort of monthly, 6 weekly, to look at the use, to look at the activity, to look at the comms, the communication and anything else that's happening, and then to see what they can adjust or what they need to do more of to encourage women wherever appropriate to actually use this type of service. And then that helps build the picture. So we wouldn't be expecting at the early stages for there to be, you know, a rush towards using the service, but there might be. We might find that certain groups are using it more than others, and that kind of independent panel that would be made up of both professionals from within the NHS and community representatives would then be making recommendations and looking at things that they could do to improve the use of the service. It could be that certain communities are more pro to use it than others, and particularly where the General Hospital site is located within that kind of community, within the BME community particularly, it might be that there are certain factors there that are encouraging women to use the service or not. So, for example, the other night we met with the Federation of Muslim Organisations Women's Group, and we were talking to them about this move, and they were very positive about the idea that the service would be located over at the General Hospital, because they wouldn't go to Melton, but they would certainly welcome it being closer to them as an opportunity not to just have to go to the Leicester Royal. So this opportunity to co-produce the panel that would then look at the usage is something that we will absolutely be putting in place. But again, to remind you that this service won't actually happen, these changes won't come into force until the maternity hospital is built and the services have been moved across. So we're looking around 2024 to 2025 at the earliest. Thank you.
Okay, I think, Ian, did you want to come in again there?
Yeah, so I think the point that Justin just made illustrates exactly what this is about. That the group that he was referring to that had the conversation the other evening, indicating that they can't go to Melton, but they would be very pleased to have the option of being able to access a service on the LGH site, is precisely why we're talking about the plans we are. Essentially, that represents a group of people who largely are much more difficult to engage with as a community, and we need to be able to engage with them in a way which is on their terms, and engage with them in a way which encourages them to be able to make the choices. Now, they may decide they don't want to use that facility for whatever reason, but at the moment they don't have that as an option.
Thank you, Ian. Elizabeth, I don't know whether that's a legacy hand or whether you want to come back in again.
Yes, could I?
Of course, yeah.
I'm not opposed to the idea of having a unit in the general. You know, it looks quite good, a good idea. But what about the people in Melton who wouldn't want to come into the city? What kind of I don't get the impression that there has been a good dialogue going on. Obviously, I don't know because I've not been involved, but I get the impression that there hasn't been such a good dialogue going on between the people in Melton and the hospitals. And I wonder about the kind of information that's being given to the people in Melton. For instance, about the costs of holding the centre. As far as I can see, it's just bland generalisations that have been given in response to questions about that, and not detailed factual information, which I think if people can be on both sides need to listen, but if they're going to have a sensible discussion, they all need to know all of the facts, not just comments, and have to accept comments from one side or the other. How much listening has been going on? For the Melton ones, I mean.
Yes. Shall I take the first part of that, and then if Flo and Ian want to come in terms of other work? So in terms of the reach and the activities that we've had, not only on the proposals for midwifery-led unit, but for all the proposals, we've done some quite extensive activity across Leicester, Leicestershire and Rutland. But obviously we know that for Melton that we needed to do additional work to ensure that people knew of the proposals, and also that they had the opportunity to come to events like these, and they had the opportunity to visit our website, find out further information. So what we've tried to do is certainly embed ourselves into the various online community groups that exist in Melton and the immediate surrounding area, so that we can have conversations using social media. We've also used quite extensively both newspapers and local radio stations to make sure that advertising, but also that opportunity that on top of the advertising that we can do interviews with members of both the CCG and the team from UHL, so that things can be talked over in that way. We've also reached out to the various parish councils and to the council over there as well, because they are a great source of information and passing information out, as is the local MP there, who has supported getting information out to people. We're also very conscious that you know, online digital isn't for everybody, so we've also gone back to a lot of our traditional ways of communicating, and I've certainly got a colleague on the call now who has been out and about in the car, dropping off leaflets, dropping off banner stands and that sort of thing, to make sure that we have a presence in various communities, including those in Melton. Obviously, the aspect of our staff is key, so I just wonder if Flo and Ian want to come in as well to talk around conversations that we've had with staff.
Yes, we have had consultations with the staff. We've been out to them twice, myself and Ian and Elaine, our head of midwifery, and we've met with the staff. Also, this process has been going on since I was in post in 2018, and that was before we actually got the money agreed from the government. And we were actually going round the whole of Leicester, Leicester City and Leicestershire, and I remember doing a meeting in Melton where we had lots of councillors there, as well as a really good turnout from members of the public. Also, the Facebook group as well, the midwives actually have been posting about the closure of Melton on the Facebook page, and the Save St Mary's group have all got involved because of the information that they've received directly from UHL. But it isn't anything new. We've been talking about this since 1990, when the other birth centres closed. So the information is out there, and we welcome people getting involved and asking more about it. But, you know, the costs, Elizabeth, you said, you know, you wanted to know about, you know, the difference. I mean, basically, we need to staff a service for 24-hour cover. So you've got midwives there, you've got support workers, we have students. And as we've said before, the birth rate, you know, is not as high as we'd like it to be. And I'll give you an example. I went there on Monday and there was no one in labour, and they'd got one lady on an 8-bedded ward, and she was going home. And she hadn't delivered at Melton, she delivered at the Royal and had just gone there for one night. And there were 3 members of staff on, 3 midwives and a support worker, and there were 5 students. So, you know, of the numbers seem, you know, difficult to digest. That's the reality of what we're working with. And those midwives could have been doing extra home visits on people, supporting them, giving them breastfeeding advice and support. So we hear what people are saying, and we're very conscious of not wanting to take services away if the services are being used effectively. But you know, we're just thinking of being more creative, because we've got this fantastic opportunity to spend this money in a different way that can reach out to more women, and that, you know, home births will still be available. The standalone birth centre at the General will still be available, as well as the alongside centres as well. And for women who haven't got transport, we've always had women that haven't had transport, and that's where the ambulance service come in if required. Do you have
so
anything, Ian?
I think I mean, Flo's given a very good example of the difficulties of being able to run the service. I think we've been very clear, actually, and very straight and very honest over decades. In fact, since I've been in Leicester, that Melton has been challenged for a long time, as Flo says, since other birth centres were closed. And we have tried hard, although the group that is representing Save St Mary's would suggest that we haven't. We have tried hard to encourage women to consider Melton as an option for having their babies. Now, interestingly, the Ockenden report, I think, is suggesting, my understanding, and I haven't read it in detail, as I said, is suggesting that you do have to tell women, if they're going to be having their babies in a peripheral standalone birth centre, you do have to inform them quite clearly of the potential need for transfer, how long that might take, and what the risks might be. And that's something that is obviously quite likely to discourage many people from deciding to have their babies away from the main centre and to have their babies in a standalone birth centre. And so if you're going to be honest with women and give them an option, you do have to point out to them that that is something they would need to consider. And at the moment, we might be criticised for trying to discourage by giving that information to them. But without giving them complete information, they can't make an accurate choice. So we have promoted it as much as we can as an option. Just to put some numbers to it, in September, there were 14 babies born at Melton, and in October, there were 9. Now, that's looking at a rate, back at its peak, back in May, during the peak of COVID, there were 24. So COVID definitely did result in some extra activity at Melton for women that didn't want to come into the hospitals, mainly I think because they were frightened and concerned that they might be exposed to a virus in those circumstances. But it does appear as though actually that the Melton activity is very difficult to expand. Now, at the moment, a birth at Melton costs us £4,000, costs our healthcare economy out of your taxes £4,000, whereas a birth at the Royal Infirmary or the General costs just around £2,000, the Royal a touch over, the General a touch under. And those it should be much more expensive services to run because of the equipment, because of the staffing levels you perceive you need, because of the acuity of the women, etc., etc. So at the moment, with the current levels of activity, a birth at Melton does cost more than twice as much. And that just isn't something that's realistic or sustainable. Now, we're conscious that it's a fantastic service for women, and we're conscious we don't want the women of Melton not to have a standalone birth centre as an option if that's what they would like to access. And so they will have that, but it will be at the Leicester General Hospital site, not at the Melton site. And that means they will have to travel some distance to get there. I accept that. But we can't, in the circumstances, run 2, particularly one that's really very small with low levels of activity up in the northeastern part of the county. And it is the case that people from Leicester and South Leicester can't travel to Melton, and they're much more likely to travel to the General. So those are the reasons. I think we've been really clear and really straight about it. It's not something that is accepted by particular group of people that understandably value their local service, but in the end we have to do what's best for the overall for the people of Leicester, Leicestershire and Rutland.
Thank you, Ian. And I've just been sort of reminded by a colleague as well, because you're quite right in terms of, this is also a listening exercise for us. And a really good example of that was a couple of weeks ago with our colleague support from the Leicester Mercury newspaper. We actually did a Facebook Live event, and at its peak there was about 500 people at that event, and numbers are still going up in terms of people viewing that, but I think it's something around about 20,000 views. So it's really that significant as well.
I think it's over 30,000 now.
Oh, I beg your pardon, Ian, beg your pardon. So just before, I think you've got your hand up again, Elizabeth, I just want to just say to other people on the call that if there are any questions around other aspects of the proposals, whether we're talking about the treatment centre, the children's hospital, or plans for Leicester General Hospital, please feel free to raise your hands and answer those. So Elizabeth, I think you wanted to come back in again.
I only wanted to say that one of the other things that can put women off from choosing to have their baby at Melton or possibly in the future at the General will be the threat of possible closure. I mean, the threat of closure has been, as I understand it, has been hanging over the Melton maternity facility for nearly 10 years. And the threat of closure at the General will be over a year, and I think that will put a lot of people off. I also would like to know a bit more about how you arrive at the it's interesting to hear that a birth at Melton is considered to be costing 4,000 and one at the infirmary 2,000, but I'd like to hear the facts and figures and how you arrive at those figures. But I think I've hogged it enough. That's enough for the moment.
I will just ask Flo though, did you want to just come in around the the commitment in terms of the midwifery-led unit for Leicester General Hospital?
Yes, obviously, as we've said on previous meetings, the way we're working as midwives is changing. So, 4 years is still quite a long way away, and by then we anticipate that we'll be working in a very different way. So we'll be working in a continuity of care model where teams of midwives will be looking after women, and they'll meet them antenatally, they'll look after them in labour, and they'll see them at home as well. And women are, when you get married, you book your venue 2 years before you get married, don't you? And, when women have babies, they're very invested. So they look around at what's available and decide where they'd like to go. They go on a tour. They can have a virtual tour, which is online, and they also go in person pre-COVID. So we do encourage people to come and have a look and see what services we offer. But as Ian said, when women come, we actually do an intention to birth at 36 weeks, and we actually talk through all the reasons they may be transferred, because we have to give women informed choice. So we don't want women to turn around and say, well, you didn't tell me that, I may have a hemorrhage and I may need a surgeon and I may need to go to theatre or things like that. So we always tell them antenatally. So women are very involved in the whole process, and they decide, where they'd like to go. But the commitment from a midwifery perspective is that we want a standalone unit because we know it's important to a lot of women. We know that for one reason or another that, women choose not to give birth at home. They might have children without childcare. They might have pets, and they just choose to deliver in a low-tech environment. And that's what we'll be offering at the General. Now, one of the reasons it costs so much to run St Mary's is, as I said last week, there were 8 members of staff and 1 patient. So obviously, if that's how they work on a daily basis, that's difficult to sustain. But also at night, there's 1 trained midwife on with a support worker. So if someone comes in labour, then they use a midwife from another team, the home birth team, who then goes over to support them. So that's why it's so expensive to run, because basically there's, not much activity, but we still have to provide the heating, the electricity, the staff. And that's why it's just so much more expensive.
That's lovely. Thanks very much for that, Flo. Now, we haven't got any hands raised at the moment, but I just wonder, because we've concentrated quite a lot on maternity. Andrew, I couldn't just ask you just to come in and just very briefly just give people that overview of the other parts of this proposal, so that if people were thinking they've got some questions, that it will just prompt them.
Thanks, Sue. So yes, I won't talk about too much about the maternity side of things, given that we spent quite a bit of time on that. But in terms of the other developments, what these proposals we're consulting on is moving acute services. So those are your inpatient emergency services and your planned care operation type services, and putting all of those on the Leicester Royal and the Glenfield site. The Leicester General will still be a hospital at the Leicester General, but it will have a different feel to it. It will be more of a community healthcare campus. There will be some services that are left there, so there will be a diagnostic hub that's left there, so that for things like X-rays and other forms of imaging that we do. There will be rehab beds for stroke services. Our diabetes centre of excellence will remain there, which has some outpatients associated with that for patients with diabetes. Inside that building is some of our research facilities, including our patient recruitment centre for some of the national trials that we do, including the COVID vaccine trials that we're running at the moment out of that centre. And obviously we've talked about the fact that it's our intention to move and have a midwifery-led birthing unit on the Leicester General site. Alongside that, we're also CCG colleagues are also looking about potentially putting some GP services onto that site as well, to create a more of an urgent care centre, primary care-led service on that site. So that's the Leicester General. The Royal will still be our main emergency site with our emergency department. On that site, the major headline buildings, if you like, that we're planning to build is there will be a standalone children's hospital. Now that will be in the current Kensington building, which is where the maternity services are currently provided. I know Elizabeth's heard this before, but for others on the call, you may not realise that we have the largest children's service in the East Midlands in Leicester, but it often doesn't feel like that because the services are spread across 2 sites at the moment and in multiple buildings. And the intention is to bring all of those together to create, although it's an existing building, the building will be completely refurbished and will have facilities that are appropriate for children all in one place. And I think that's a really exciting development for Leicester and Leicestershire and Rutland. The other, there will be a maternity hospital on that site, but we've talked about some of that to some extent already. The other major development for the Royal will be a substantial increase in the ITU beds on that site. So these plans for both the Royal and the Glenfield result in almost doubling our intensive care beds from just over 50 at the moment to about 100, and that's a significant investment in intensive care for the sickest patients that we see and treat, and that's for some time now we've been under provisioned in Leicester in terms of our intensive care capacity. So I think again that's a really positive development for the city and the counties. At the Glenfield, one of the major developments there will be the treatment centre. This is a significant building which will increase the footprint of the Glenfield by about 1/3, and that will have a significant amount of outpatient, day case and some planned care operations taking place out of that building. The reason we want to do that is we want to try and separate as much as possible planned care services from emergency services, because at the moment too often people's planned care operations are cancelled because other services are being overwhelmed by the emergency work that's taking place. By offering separate dedicated facilities, we think that'll offer much more certainty for people having their planned operations. The other benefit of doing that is that it will remove a significant amount of footfall away from the Leicester Royal Infirmary, which is our most congested site. So it will take away about 100,000 day case procedures and about 600,000 outpatient procedures away from that site. 47% of the footfall will move away, and that will allow us to do some really interesting and innovative things with the Leicester Royal Infirmary site in terms of opening that up and making it much more easy to find your way around. And alongside that, we're also going to be building some additional car parks on both sites, which should help with some of those congestion things, and also working with the City Council on some really interesting initiatives around green options for transport and things like that. So those are the headline things. There are also some ward refurbishments and things that are going on for the £450 million, but those are the big buildings that you will see change around the sites.
Lovely, thanks Andrew for that summary. That's really useful. So at the moment I'm not seeing any hands in the chat box, so I'll just start to wrap up the event. But if there is anything while I'm doing the summing up, then please do raise your hand if something comes to mind from what you've heard. So
just before you do that, it's probably worth saying that if people haven't got questions, there are a lot on the website now. There are a lot of frequently asked questions, including videos of other members of the team answering some of the questions that people have asked at other events, which may cover off some of the questions that people may have or want to ask.
Yeah, thank you. That's a good point, Andrew. Lovely. So I mean we've got now until the 21st of December for people to participate in the consultation. It's been a really good month in terms of December. The big burst that we saw at the beginning, we're now seeing a big burst of people getting involved at the end. People very often leave things to the last minute, so that's good that people are getting involved. So anybody on the call, do encourage, if you haven't already, family, friends, as well as completing the survey yourself. That's www.betterhospitalsleicester.nhs.uk, and that links you through to the survey. We've actually run right the way through the consultation. We've advertised a telephone number so that if people don't feel that they want to go online, or they don't want to just ring and get a hard copy of the consultation questionnaire, that they can actually ring us up and we could arrange for somebody to go through the questionnaire and fill that in. What we're doing towards the end of this week, so Wednesday, Thursday, Friday, is we'll be actually manning those phone lines, and a few of us from the engagement team will be manning those phone lines, so we don't have to arrange for a call back. So again, if you know of any communities where that opportunity to have those conversations over the phone and fill the questionnaire over the phone is something that would suit them better, then do pass on the telephone number. Between 10 and 4, Wednesday, Thursday, Friday, those phone lines will be manned and you'll be able to speak to somebody from the engagement team. Or you can people can email us. So lots of ways that they can get involved. So no further questions in the chat box. Oh, sorry, no, Elizabeth, I think you've got your hand raised again there.
I haven't got a question. I've just got a comment. I just wanted to say I very much appreciate the enthusiasm, the dedication, and the vision that all of you who are organising all of this have got. And I don't want to sound as if I don't appreciate that, but I know that when you're full of enthusiasm and vision, you can miss little things. And I'm talking just from my personal experience now, nothing to do with maternity, because obviously I've never had any experience of that. But I'm very fortunate that I've not often had to be involved in going to hospital. But travelling into the infirmary, I have found impossible or very difficult. I always come by taxi. And when the reorganisation of the infirmary took place a few years ago, I discovered that the management had forgotten to ask or make arrangements for the taxi drivers to drop their patients off. So I have great difficulty getting from I think it's gate 9 to where I need to be. And it's that tiny little detail that can get missed, I think. And recently I looked at all of the services that are going from the general to Glenfield. And I hope I never will have to use any of those services, but I had to go to Glenfield recently. It cost me £50 with a taxi to go to and get back again. And basically, so on a personal basis, I am bothered, but that's minor compared with all the other things that are going on. But I wanted to pay tribute to all the dedication and the enthusiasm of all of you who are involved in this. And I wouldn't want to do it myself. So thank you.
Thank you for those comments, Elizabeth. And you're quite right. I mean, that's why we're doing these events. That's why we're having a lot of dialogue throughout the consultation, because by listening to people, then we can only make the proposals even better than they are. So, we do appreciate your comments and your the constructive challenge that you put in. These plans aren't going to get better if we don't hear that. But I think, Andrew, you want to come in?
Well, I was just going to say thank you, Elizabeth, for those words, but also just to say that this is exactly what all of these events are about. It's that absolutely appreciate it's the little things that can make a massive difference to both experience and confidence that people have in their hospitals. So it may come across that we are very enthusiastic about this, which we are, because that's probably because some of us have been working on these for maybe 20 odd years. And I think I've said before to you, at one point, I was hoping I'd be building these hospitals to work in. I think increasingly I'm building these hospitals to be a patient in myself. So I have a very strong vested interest and want to make sure that these are right as well. But it is really important that we do listen to people. And I just wondered whether it might just be, I think you might have heard it before, Elizabeth, but I think it's important that the transport one, it might just be worth just telling you how you can get involved in that and what we are doing on that. And I don't know whether Justin or Darren want to just talk about the transport stuff, because I think that is, I think it is really important. I do think that it is. I've been to hospital sites. I know how difficult it is to park, and these things matter, and it just makes your day much more stressful, doesn't it?
Yeah, no, that's quite right. Justin, do you want to just talk around how people can get involved in that both now and in the longer term, and then Darren, if you just want to talk through the sort of plans.
Certainly. So we've engaged a company called Go Travel Solutions. They are well known to Leicester, Leicestershire and Rutland. They're experts in sustainable travel, and they've been working alongside us now for a few months to look at our travel plan, and then to turn our travel plan, which is on our consultation website, but it's quite a technical document. It's not very user friendly. It serves a purpose for highways, but it's not really the kind of thing that you or I would particularly find interesting. So they've translated that into a travel action plan, and they've been working to set up forums and groups to reach out to people that want to be involved, to actually listen to people's experiences of traveling to our sites, and then to look at alternatives ways that we can do it. So Elizabeth, your point there around taxis coming to the sites and making sure that wayfinding is appropriate, all of that's being built in. They've also looked at electrification of the bus routes, looking at more park and rides around the city and the county, so working with both the city and county councils and highways, working with the bus companies as well, because the bus companies are keen that we use their travel rather than use our cars, obviously, because it brings them an income. So they're really wanting to make sure that actually the routes around the city and around the county are beneficial to the patients to get us to the sites easily, and means that actually we don't bring our cars into the city if we really don't have to. They've also been working with the city, particularly around Santander bikes. Now, this is a new initiative. It's come with quite a lot of investment for the city to actually bring in electric bikes across a range of routes around the city, going out as far as Glenfield, where basically you rent the bike for the journey that you need to get to. So it might be that someone arrives at the train station and they don't want to walk down to the Royal Infirmary, but they could pick up an electric bike at one point, cycle down to the Royal, and then park the electric bike and then into the hospital. So there are going to be a range of these electric bikes parks effectively all around the city and go into the county as well. The key thing is that all of this information is coming into the travel forum and the travel steering group, which are multi-agency groups. We've got Health Watch on there and other representatives to make sure that we're really listening and we're really engaging. And then that will take us beyond consultation. So all the feedback that we're getting now from the consultation surveys, we're feeding that in on a weekly basis into those groups to make sure we've not missed anything and we've captured all the views. But that will take us out the other side of consultation, and then over the years that we're making these changes, we will then be involving people in how we do that well. So yeah, Go Travel are doing a really good job, but again, I'd really urge people to get involved, to get involved through the survey or through the website and tell us your experiences. Thank you.
And Darren, if you want to come in, because I know you've got a lot of experience with these and other projects across the country.
Yeah, it's a really good question, Elizabeth. And I nearly thought I was going to get away today without having to answer a question about car parking. Justin's covered off really comprehensively what we're doing about trying to improve travel and everything else. But as Andrew said, we have got plans to improve our car parking facilities. But it isn't actually just what we're planning to do off the back of the reconfiguration program. We know one of the reasons that people suffer with car parking at the Royal, particularly, is the aging technology that we've got. So we have got plans through what we call our sort of capital program towards the end of this year and into next year to actually replenish some of that technology and introduce new technologies, which involve things like automatic number recognition systems, what are called quick response codes, so that we can start to also look to implement some of the manifesto pledges that around hospital car parking. But as equally, I think was said earlier, it isn't just when you park, but it's how and how you get to the site, but how then do you navigate through the hospital? And we know that that's challenging. The Royal's got something like 24 separate entrances. So part of the benefits of this broader scheme, should we obviously depend upon the consultation and how we progress it, but will be to endeavour to build anew what will effectively be a single main entrance for the site as much as we can, and try and encourage as much flow through that entrance as possible, so that we make the whole wayfinding around all of the buildings a lot easier. The dynamics of car parking will change, because if we put a maternity hospital on, by necessity, we'll have to provide more drop-off type areas, and that'll be something which will be open not just to patients and visitors to use, but also for taxis as well, so that taxis will be able to get closer to some of our buildings and be able to drop people off directly. We always have ongoing challenges at times with taxi companies, because they do sometimes think that they can arrive on site and sort of navigate even through areas that they shouldn't go. So we have constant dialogue with taxi companies, but we realise they are a really important part of travel for people who don't have their own vehicles and who don't want to use public transport. So part of the group conversations we have are going to be with taxi companies as well. But what you'll start to see through as these plans progress is the whole dynamic about car parking and access starting to change through our sites, which again is really exciting. And it's something, you know, I'd love, Elizabeth, to have a big greenfield site somewhere and just build a new hospital and almost, you know, close one hospital down on a Sunday and open the other one up on a Monday. It never happens that way, unfortunately, like it sometimes can in other sectors with schools, and if you're building a hotel and others. Hospitals tend to be a little bit more challenging, and our scheme is challenging because it's not only some new builds, it's refurbishment of existing areas and trying to keep do that whilst we're keeping the hospital live, and is always a challenge. But that's what we're here for. You know, we're really up for it because, as Andrew said earlier, it's a once in a generation opportunity to bring this investment into the city, but not just in the city for the health. It's also there about the broader impacts on the economy that we'll have across LLR, because, you know, nearly £500 million brings with it a lot of what we call social value opportunities as well. So it's opportunities to revitalise and invest in the economy, which is why this whole thing is so super exciting. And that's why we can sometimes in these events run away with ourselves and use lots of acronyms and other things, because we just get so excited by it all.
Thanks. I know Ian's got his hand up, but just before coming to Ian, I just want to remind everybody, but if there are any questions, just raise your hand, and I'll come to you. Ian.
It's just to echo what Sue and Andrew really said, Elizabeth. I think I think we just need to thank you for engaging so actively with these meetings. I think it's really important for us to be challenged and to be able to respond, so that firstly, you know, we can listen to people's concerns, but also because it's quite difficult to explain the complexities of the reasons that we're making the proposals that we are just on pieces of paper, and without being able to answer some constructive challenge. So I think it's great, and I wish more people would engage in the way that you have.
Thank you for that, Ian. So I'll just check to see if there are any hands raised. So I'm not seeing any hand. Oh, sorry, Phil. Phil, do you want to? Is that a hand raised there that I saw from Phil?
Yeah, I'm just trying to fiddle with all the switches. Am I on?
Yeah, lovely. Welcome, Phil.
I've listened to a lot of these broadcasts. First of all, I'm on the patient participation group of Uppingham. The only time I ever hear Rutland mentioned is actually in the title, is when you mention LLR. And I know this applies to other extremities. I'd like sometimes somebody to think about what's happening on secondary care. Everything they say, we're closing down community hospitals, yet we want things moved into the community. And everything seems to be going into the centre of Leicester, which is why we're worried about car parks, transport and all the rest of it. And I praise what they're doing, like the lady before said. We've got nothing against what they're doing there, but we feel that the more that goes into those efforts, there's less available for the secondary care that you're trying to promote.
No, it's a very good point, Phil, and you know, it's great to have you on board in terms of Rutland. I mean, we have been doing a couple of events that have run side by side with the conversations about the acute maternity over in Rutland, both last week and the week before, just really to talk about those important aspects of what care might look like from your GP practice, from your within the community, and from the memorial hospital. But does anybody want to just talk around the sorts of things that we're trying to do in getting more care closer to home and reducing services from hospital. Is that something perhaps Andrew or Alice, do you want to come in?
Well, I probably can't talk about it in a great deal of detail, Phil, but what I can say is, as Sue said, Andy Williams, who is the accountable chief exec officer for the 3 CCGs, I know there was, and I have been on some of the events. We've had a number of events, both with the Rutland Council, and also there was a fairly detailed event, I think, in the last week or so, where actually, because I understand the tension, because some of what we're doing the consultation on is about the acute and maternity services in the 3 hospitals within Leicester, and so it feels like we're not talking about the counties and Rutland in as much detail as perhaps people would like. But I know that the CCGs through Andy Williams are doing what they call place-based discussions. So you may have heard this terminology now. So we talk about system, place, and neighbourhood. So place is based on unitary council authorities. So Rutland would be a place, and Andy and the team have been out to specifically talk about what the plans are for how Rutland Memorial Hospital and the GP services will be structured. So it sometimes feels like we're only talking about the hospitals, and we have had that feedback before, but that's partly because that's what specifically this consultation is about. But this sits within a bigger plan in terms of how we provide the health services and social care services across the 3 places, which is Leicester, Leicestershire, and Rutland. Alice may want to come in and say a bit more on that.
I think Andrew, you did a great job of summarising that. You're absolutely right. I was going to say we are talking around system, place and neighbourhood, and those conversations are happening alongside the consultation to make sure that we aren't just thinking about one part of healthcare and how important it is to have care closer to home. I haven't got the details right in front of me today, but Phil, I'm more than happy to have a conversation with you offline about the community services, and I'm sure one of the team can provide my details so we can discuss next week around what that looks like and how you get involved.
Yeah, but the reason behind the question is you have put out a questionnaire which we are involved in, and I'm not talking about, although I'm in Rutland, I'm talking about probably places like Colville, which will have the same thing. Everybody's coming to me and saying, how can I fill in a questionnaire about local hospitals when I don't know what's happening locally? The questionnaire is designed about what we do, how we do it, but we don't know what's going to happen when our stuff is being closed down. The Rutland Memorial Hospital has been under threat since I've been in Rutland, which is 14 years. I think we should change the name of the place. It's not a hospital. It should be our community services hub. Yet Andy Williams said last week, he said it'll stay open, or it's equivalent to stay open, but it's up to Rutland what they want. When he was asked who would pay for it, because all the money's going into Leicester, there was no answer. And therefore the people in the community don't have a clue and they can't answer the questionnaire.
So Phil, just on the question of all the money going into Leicester, so I'm sure you're aware this is separate money to what we would normally get for providing healthcare, and actually overall this will make services more efficient for acute hospital services, which will mean that for a system that the system deficit is reduced down, which means that potentially is more money to invest in other areas. And so I think I can't speak to the CCG plans for place, but as a system, we are all involved in the system. So secondary care services and we have a duty to try and spend that public money as efficiently and as effectively as we can. So if by doing some of the proposals that we're planning to do with the acute services, that means that the overall costs of running a healthcare for the bit that I have responsibility reduce down, that should help other parts of the system, because we now just have one system budget.
Yeah, well, what I'm trying to consider, and I'm sure you appreciate all this, if you talk about other things like NHS choice, nobody's ever mentioned, which comes up. Air ambulance takes you somewhere else. Ambulance services in East Midlands, certainly as far as we're concerned, could drop you at any hospital, anywhere at any time. A lot of Rutlanders don't use Leicester because of waiting times and the administration, which at the moment is not good. And for us, my wife is using Kettering Hospital at the moment. I'm using Peterborough. Rutlanders don't go to Leicester. And therefore, because we don't know what's happening to our local services, that Andy Williams keeps on referring to the fact that you want services in the community. And yet you're closing them down. And the question about Melton sort of covers that to a certain extent.
Alice, do you want to come back in there?
Yeah, absolutely. I think what I've heard from you, Phil, is that more information is needed to be able to fully respond because of the crossover between the two pieces, so secondary care and community care. I think the CCG have taken steps to start that conversation, so the meeting with councillors and residents. What I will take away is the feedback that isn't enough right now, and I will speak to colleagues about how we can link the two up and where we are in terms of publishing any design ideas, again, which we will do that in partnership. So part of that is around this is what we're thinking and this is what it means, and we'll see how far away we are from that. So rather than responding today, I'll take that away as a comment to look into and see if we can do something with that.
Yeah,
thanks very much.
Lovely. And just to sort of remind, I think, you know, it was very much the two events, like one last week and the one week before, they were the start of that conversation. So you will hear a lot more Phil into the new year in terms of Rutland, as will other areas across Leicester, Leicestershire and Rutland. It's it's a good point, well made.
Well, you've just made my point, which is after the consultation closes. And Andy Williams has said that consultation will not be extended in any way. If we just bear in mind what I'm saying, it's after the consultation closes that we find out what we might get, providing the money is there.
Yeah, I think these plans do stand alone as well in terms of the plans for the proposals for the hospitals. So they do stand alone in their own right as well.
Fine, I'm just making the point if you bear it in mind.
Yeah, no, that's appreciate that feedback, Phil. So I'm just checking the box again. So we haven't got any other hands raised. So I've just asked the team if there are any last minute comments that you want to make, just whilst we're waiting, just in case there's any last minute questions. No. Okay. All right. Well, if I could just summarise by thanking you all for participating today. I appreciate it. It's a Saturday afternoon as well. And thank you for all your questions, all your comments. Just to remind you, we've obviously got people in the background who have been taking those points on board, and we've also recorded it so we can make sure this contributes to the overall consultation process. If you haven't already completed your survey, then please go online or call us on the telephone number that we've been putting in the chat box for people. And then just to remind people that if there are communities where it would be easier to have a telephone call and we go through the questionnaire, then Wednesday, Thursday, Friday, I mean, that number is available all the time, but Wednesday, Thursday, Friday, we've got a dedicated team, so there won't be any callbacks on that. So once again, thank you very much, and I hope you enjoy the rest of your day. Thank you.